I have the privilege of introducing you to Dr. Fernanda Costa. I would like to really thank her for accepting to present at a Sono webinar and to bring all that knowledge and expertise and that point of view from Brazil. I think it's great to be able to learn not only from local speakers, but also from international speakers. So she is a vascular surgeon and vascular sonographer in Salvador, Bahia in Brazil.
Oh, hi everyone. It's a pleasure to be here sharing knowledge with you. I would like to thank Aprende Canada for the invitation. And firstly, as this is my Sono webinar, let me introduce myself briefly. My name is Fernanda Costa. I am a vascular surgeon and vascular sonographer from Brazil. And today I'm going to cover the topic diagnosis and treatment of varicose veins from the Brazilian perspective. For a start, in Brazil, the diagnosis itself is only permitted by doctors according to our federal regulation. For that reason, only physicians are allowed to perform diagnostic ultrasonography in Brazil. What does this mean for the treatment process? Usually, the person who will perform the exam is the same as will make decisions regarding the patient. So, if I am a vascular surgeon, I want to be satisfied and just given the correct diagnosis of a varicose vein. But I have to make a map which will guide me in future procedures. As I have this surgical view, maybe I can help you to perform the exam as required by the surgeon. These are the references I used for preparing this lecture. Zwiebel and Pellerito are very known authors of ultrasonography internationally, and Maffei is a very recognized vascular surgeon in Brazil, so his book is a reference for board certifications here. And I also use the guidelines of the European Society for Vascular Surgery. Well, chronic venous disease has a high prevalence. The presence of varicose veins ranges from 20 to 64% in the overall population. This rate varies a lot between the studies, especially because of the accuracy of the new methods, including the ultrasonography. Doppler ultrasonography is the gold standard for the diagnosis of varicose veins, according to the guidelines of the European Society for Vascular Surgery. Despite the accuracy of the method being higher for the femoral popliteal segment than for the distal leg veins, it is the preferred exam for the preoperative assessment of patients. Its major advantage is that it consists of a non-invasive technique with a low cost and it is easily accessible. Before starting the exam, it will be beneficial for you to know some of the pathophysiology of chronic venous disease, the CVD. There are lots of classifications and quality of life questionnaires about CVD, but the most practical and the most applied worldwide is the CEAP classification. Don't worry about memorizing it. I've broke this table to illustrate that there are at least 6 phases, 6 stages of venous disease. So in your report, if you just say that you found varices on the distal leg, for example, it will not be enough. The more advanced the phase in the CEAP classification, the more probable is that you will find a severe reflux with a large number of veins affected. The CEAP classification describes the disease according to its clinical presentation, its etiology, the location of reflux, and the pathophysiology, the mechanism which causes the disease. So when no visible or palpable signs of varices are found, you name it as C0. C1 when you find telangiectasia, the spider veins, or reticular, small varicose veins. C2 for varicose veins itself, the large varicose veins. C3 for oedema. C4 are skin alterations, and this classification is divided in A or B. A for hyperpigmentation or eczema, and B for lipodermatosclerosis or atrophy blank. C5 for healed venous ulcer, and C6 for active venous ulcer. According to the etiology, the varices can be congenital. For example, when you perform an exam in a baby, or it can be primary, most of the times genetic, can be secondary, most of the time to a deep venous thrombosis, and when you don't find any venous causa, you name it as EN. And according to anatomy, the varicose veins can be superficial. When you find the superficial veins, when the superficial venous system is affected, and AD for deep veins, AP for perforator, and AN when no venous location is identified. And according to the pathophysiology, PR when reflux is found, PO when obstruction is found, and PRO when both are found. PN when no venous pathophysiology is identifiable. Here I have examples of each stage of a chronic venous disease. In the first clinical stage, CEAP-C1, you will find the spider veins, as I mentioned before, which have less than 1 millimeter of diameter, so they cannot be evaluated on ultrasound. And you also will find reticular veins, these blue veins, which are intradermal veins with 1 to 3 millimeters of diameter. Sometimes you can see the reticular veins and you have to report them on your report. But most of the time, these veins are compressed by the transducer during the exam, so they aren't an obligatory part of the protocol. You don't have to describe each varicose vein found. In the same way, for the stage C2, varices are found which are 3 millimeters or more in diameter and are located in the subcutaneous tissue. You should report the larger veins, their location, and if they have any connection with the saphenous veins. For C3, you will find the interstitial oedema on ultrasound, which you should report. For CEAP, C4, C5, and C6, you should report all the limitations to sonography. In C4, skin sclerosis can make the area difficult to compress, so your ability in evaluating the compressibility of veins is limited. And the same can be reported for C5 stage, where some degree of fibrosis from the ulcer healing process can be found. Observe that according to these marks, this is the same patient. Here he had an ulcer, he was treated, and then he became a C5. But you can find these skin alterations, fibrosis on ultrasound. For C6, sometimes the patient is wearing bandages that cannot be removed, or the ulcer itself does not allow appropriate evaluation of the area. So you have to describe any reason that makes your exam incomplete. Okay, everyone can hear me because I received a message about my unstable connection. So let me know if you are hearing me. Okay, okay, thanks. Let's continue. Okay, okay. So the protocol for duplex evaluation of varicose veins begins by choosing the appropriate transducer. Most of the time, you will use the linear transducer, which ranges from 6 to 15 megahertz and allows 6 centimeters of depth. These transducers are from the SonoSight machine I use in my office, but the frequencies and the depth varies according to the machine you use. And sometimes you will need the convex transducer, especially in obese patients, because the femoral vessels and the saphenous femoral junctions are deeper in these individuals. So the convex transducers ranges from 2 to 5 megahertz and allows 30 centimeters of depth. And we also use the convex transducer when a complementary evaluation of iliac veins is necessary. To achieve the correct measurement of vein reflux and diameter, the patient must be in a standing position. The lateral rotation of the limb makes it easier for the transducer to be moved along the limb. This position allows you to obtain images of both the superficial and deep venous system. Usually, we spend 30 minutes scanning both limbs, but for patients who cannot stand for this period, you can evaluate the deep venous system with the patient laying on the bed, then proceed to the superficial vein scanning in the stand position. However, you should describe this limitation in positioning in your report. So in a standing position, you have the anterior medial view and you have the posterior view. Let's talk about that. Following the protocol, start the exam with the anterior medial view. You have to scan from the inguinal ligament to the ankle, evaluating the deep venous system, the common femoral vein, the superficial femoral vein, the deep femoral vein, until the level of the thigh, because the popliteal vessels you will evaluate at posterior view. Then proceed to evaluating the tibial vessels, anterior tibial vein, and the posterior tibial veins you can evaluate from the medial malleolum, either posteriorly or at the medial, anterior medial view, from the malleolum upward. Okay, and also evaluate the superficial veins, the great saphenous veins, especially the saphenofemoral junction, and all the length of the saphenous vein up to the malleolum. And that posterior view, you have to scan the popliteal veins and the Colfi veins, and also for the superficial veins, small saphenous veins, and any varices you'll find in this region. An important consideration needs to be remembered regarding the fibular veins. Because of their location inside the ligament between the tibial and peroneal bones, the fibula, the fibular veins are better evaluated from the lateral view, positioning the transducer below the peroneal bone, so you can have the access better. I hope you are following this information, and now I have a question for you. If I'm looking for varicose veins, which belong to the superficial venous system, why should I scan the deep venous system? You can type now. No answer until now. Well, let me answer for you. Always search for deep venous thrombosis, okay? When acute DVT happens, some superficial veins are enlarged as a compensatory mechanism. It doesn't necessarily mean that they are varicose veins. And for chronic DVT, patients usually develop post-thrombotic syndrome, which is the occurrence of varicose veins as a chronic compensation of flow obstruction. At other times, the primary source of reflux is located in the deep venous system after it is transmitted to the superficial vein. In this image, I have an evaluation of a normal common femoral vein, right? After checking for compressibility, you should take an image of the longitudinal view, then activate the color Doppler. Remember to adjust the scale in terms of having a complete filling of the lumen without any escape of color around the vein. Then you activate the spectral Doppler to evaluate flow characteristics. Conventionally, the flow must appear below the baseline and show a small variation according to the respiratory movement. Then you ask the patient to do a Valsalva maneuver, which consists of a deep inspiration for the reflux evaluation. Reflux is defined as a reverse flow during more than 1 second for the femoral veins, for the popliteal veins, and for the saphenous femoral junction, during more than half of a second for the deep femoral vein, the cough veins, and the superficial veins in general, and reverse flow lasting more than 0.35 seconds for perforating veins. These cutoff values were established by the guidelines of the European Society for Vascular Surgery, and the perforating veins make the connection between the superficial and deep venous system, and I will talk about them specifically later. This picture shows a typical flow pattern of the saphenous-femoral junction. Observe the velocity peak that occurs when you ask the patient to breathe deeply. It corresponds to the opening of the venous valve. When the patient expires, the valve closes. This is a normal scenario when a short reversal flow is observed. This is normal. If you see this scale below, you can observe that this reverse flow lasts less than 1 second. So this is a normal situation. This is not defined as pathological reflux. In this video, we can see the valve opening and closing in the saphenous-femoral junction. The valve is going to close it. Okay, this is the normal finding, but when the valve is damaged by disease, its closing is compromised. Let me repeat the video. Close. Okay. So it is important to know that the Valsalva maneuver is used, is used for the femoral vessels, but for the popliteal vein, superficial and perforated veins in general, you should apply the augmentation maneuver, which consists of a compression and rapid decompression of the limb at a distal point from the vessel being examined. This is because the distal deep veins and superficial veins are not as affected as the femoral veins by the Valsalva maneuver. Now let's talk about a pathological situation. This picture shows a reverse flow that lasts more than 1 second. It happens because the valve does not close properly, as I showed before, allowing the flow to continue. Okay, so this is a pathological reflux and not a physiological, as I showed in the latest picture. Let's continue. Do you have any questions until this point? So you should describe in your report which veins have normal flow and which veins the reflux is present. The perforating. The perforating veins connect the superficial venous system to the deep venous system. They are direct perforators when connecting a deep vein with the saphenous vein, or they can be indirect when connecting the deep venous system with the other superficial vein that is not the saphenous. In a normal physiological condition, their flow is from the superficial to the deep venous system. But when their valve is incompetent, a reverse flow happens. Then the pressure inside the superficial vein increases and it becomes varicose. There are more than 100 perforators in each limb, so you cannot see all of them on ultrasound. Usually they are visible when they are dilated, so you should report when you identify one in your exam. But keep in mind, if the perforator is dilated but it does not have a reverse flow, it's not incompetent. Okay, to be incompetent, the perforator has to have a reverse flow. Sometimes the perforating vein is dilated as a compensation to the high pressure in the superficial venous system. So if in your report this perforator, you say this perforator as an incompetent perforator, the surgeon probably will perform its ligation, and the pressure in the superficial venous system will worsen. Here we have some examples of perforating veins. At the level of the proximal thigh, there are the Hunterian perforators, and at the distal thigh, the Dodds perforators. They connect the saphenous vein to the femoral vein. And below the knee, draining the arch vein, there are the Cockett's perforators. At the level of the knee, the Boyd's perforators. All right. Nowadays, this nomenclature is no longer used. Sonographers are preferring to describe the characteristics of the finds in detail rather than mention the name. So don't worry about memorizing all these names. In your exam, all you have to do when you identify a perforator is to report if the flow is right, is correct, or if there is a reflux, and the distance from the foot, the distance from the knee, or the distance from the saphenous femoral junction. So you have the correct location, you are given the correct location of the perforator. Well, considering that you have already scanned the deep veins, the saphenofemoral and saphenopopliteal junctions, and you have assessed them for compressibility and flow characteristics, now we are going to see how to take measurements of the saphenous vein. The great saphenous vein and the small saphenous vein are truncular veins, which will define the procedures to be adopted regarding the venous disease. So we start by identifying the saphenous femoral junction. At the level of the inguinal region, you will find this image. It looks like a Mickey Mouse, where here is the common femoral vein, is the head of the Mickey, and the ears are the common femoral artery or the superficial femoral artery, as here we have the arterial bifurcation. And here you can find the end of the saphenous vein with the saphenous femoral junction. Positioning the transducer longitudinally, we find this picture here. It corresponds to the saphenous femoral junction augmented, okay? So usually in dissections, in surgical dissections, we find 4 veins at the level of a saphenous femoral junction. But on ultrasound, most of the times we find the superficial epigastric vein. So the measurement of the saphenous femoral junction should be taken up to this level here, the level of the epigastric vein disembowel. The flow should also be evaluated at this level, okay? And this measure here is the measurement of the saphenous femoral junction. If you take this measure in yellow, you will report a false enlargement of the saphenous femoral junction. This is very important because the thermal ablation procedures for the saphenous veins goes up to this level here. And a true enlargement of this area is a predictor of the disease relapse. So if a true enlargement of this area is found, usually we indicate another intervention. So you have to report this measurement accurately. Is it everything clear up to now? I have another question for you. After evaluating the saphenous femoral junction, how many measurements should we take from the saphenous vein? You can type. How many measurements at the length of the saphenous veins should we take? Seven, 9. Who gives more? Well, it's not incorrect if you give, if you take 7 or 9 measurements. If you find it as necessary, but you have to take at least 6 measurements of the saphenous vein, okay? But you can give more if you judge as necessary, but at least 6. Well, below the junction, you should take 6 other measurements at the level of thigh, proximal thigh, median thigh, and distal thigh. And below the knee, proximal leg, median leg, and distal leg. This protocol helps the doctors to identify at which level the vein should be treated. For example, most of the time the thermal ablation of the saphenous vein goes from the junction to the level of the knee, unless there is severe reflux or dilation below. Intervention below the knee is more associated with nerve injuries. So here we have some examples of measurements of the saphenous vein, where you can see the vein between the fascias, showing an image like an Egyptian eye. Observe the increased diameter of more than 7 millimeters at the level of thigh, while the diameter is normal below 5 millimeters at the level of the leg, below the knee. 5 millimeters is the cutoff value we apply to treat the saphenous dilation. So if you have a saphenous vein with more than 5 millimeters of diameter, and if it has reflux, you have to treat. A similar protocol should be applied to the small saphenous vein by evaluating its saphenous popliteal junction and taking measurements at the level of the proximal, median, and distal call. All right. Unfortunately, guidelines inform how to perform a standardized DUS, but they don't tell us how to write down the information in the report. So I'm going to share my personal experience with you. Even if you take many pictures, your report should describe a summary of the findings. I usually write a separate report for each limb, left and right. And considering a normal exam, begin your report by describing the deep venous system regarding patency, compressibility, and flow characteristics. If you identify any perforator, report it, even if the findings are normal. So let's see a normal report. Femoral veins, popliteal, tibial, fibula, and calf veins are patent with normal compressibility, thin walls, and phasic flow without evidence of reflux on performing Valsalva or augmentation maneuvers. You have to describe the maneuvers you adopted. Perforators patent and competent when visualized, because you cannot visualize all of them, all 100 perforators. So when visualized, it's important to write this observation. Regarding the superficial venous system, describe the saphenous junctions and the length of the saphenous veins, mentioning patency, compressibility, and flow characteristics with the maneuvers adopted. Then write all the measurements taken, at least 6 measurements, okay? And the same for the small saphenous vein. Here is an example of a report describing abnormal findings. In this case, for the common femoral vein, I described an altered morphology with thick walls and trabecular images which are suggestive of chronic venous thrombosis. I also described reflux, flow characteristics with the reflux. And I proceeded to describe normal findings. Then I reported an altered perforator given its exact location. So it is important to see that incompetent calf perforated identified at the level of 3 centimeters below the knee, medial aspect. Give the exact location so the doctor can search for this perforator at the time of the treatment. For the superficial systems, I wrote the normal findings and highlighted the abnormal aspects by writing in bold and italics. As you can see, a reflux was described in the saphenous femoral junction, and its measurement revealed an enlarged junction, larger than 10 millimeters. So for the saphenous femoral junction, the cutoff value is 10 millimeters, all right? I also described in detail the segment of the saphenous vein, which is altered, beginning from the junction up to 5 centimeters above the knee. Then I wrote all the measurements taken, highlighting the dilated segment, which have more than 5 millimeters in diameter. I proceeded in the same way for the small saphenous, describing the reflux and the dilated segment. So let's see, saphenous femoral junction patent, compressible, and with the reflux lasting more than 1 second, identifying on performing Valsalva maneuver. Measurement 11 millimeters. Great saphenous vein is patent with normal compressibility and thin walls, reflux found on performing augmentation maneuver at the level of thigh from the junction up to 5 centimeters above the knee. So I gave the exact location of the abnormal segment of the saphenous vein. And here the diameters. Okay. The same for the small saphenous vein. Reflux found on performing augmentation maneuver at the level of the proximal calf from the junction up to 4 centimeters distally. And the segment with dilation highlighted. Sometimes you can be requested to include additional information depending on the procedure being planned by the doctors. The guidelines describe lots of procedures, and its indications depend on several factors, including the general health status of the patients, their financial conditions, the surgeon experience, and the degree of disease. So, according to the European guidelines, treatment recommendations are classified regarding the level of scientific evidence. So, the type of paper published on the subject has influence on the recommendation, and how beneficial the treatment would be for the patient is also considered. So treatment with level of evidence A has the strongest level of recommendation. When data are derived from multiple randomized clinical trials or meta-analysis. Level B, when data came from a single randomized clinical trial or large non-randomized studies. And level C, it's a weak level, consensus of opinion of the experts. Okay, small studies, retrospective studies, registries. And classes 1 to 3. Class 1 is the strongest class when it's very clear that the treatment will benefit the patient. Yeah. Class 2 is an intermediate class when the data are conflicting. And class 3 when there is evidence of a possible harm to the patient. The strongest recommendation, class 1 level A, by the guidelines for the treatment of saphenous insufficiency is the endovenous thermal ablation over surgery and over foam sclerotherapy. This is because the incidence of complications is greater for surgery, and the foam sclerotherapy is less efficient than thermal ablation. For endovenous thermal ablation, it is important to take measurements of the distance between the vein and the skin, or if there is any segment out of the fascial compartment. If the vein is too superficial or is not covered by the fascia, there is a risk of burning. So the surgeon has to adapt procedural adjustments to avoid lesions to the patient. The distance from the skin also predicts the level of difficulty of the puncture. In this short video, we can see the moment when the saphenous vein is punctured for insertion of the thermal ablation catheter or fiber. Okay, can you see the catheter inside the lumen? Observe that for the puncture, the transducer can be at transverse view, but for visualization of the catheter progression, it should be at longitudinal view. Also report any signal of phlebitis inside the saphenous lumen because it has an influence on the fiber progression. Elderly patients or people whose comorbidities are contraindications to surgery or thermal ablation, the photon sclerotherapy is indicated, especially for stages C3 to 6. And for patients who don't have saphenous insufficiency, but have telangiectasias or reticular veins, stage C1, the liquid sclerotherapy should be applied. And for those who have normal saphenous evaluation but have varices, stages C2 to C3, we can remove the varicose veins by surgery, preserving the saphenous veins. For open surgery, always report if you find any enlarged lymph node in the inguinal region. It will help the surgeon to plan a careful dissection of the saphenous femoral junction, avoid lymphatic lesions. Remember to report if the varicose vein has a connection with the saphenous veins and at what level. And for foam sclerotherapy, if the patient has an ulcer, for example, it is important to report its feeder vein. A feeder vein is a varicose vein which is directly implicated in the ulcer etiology because it is very close to the ulcer area, and usually it should be responsible for drainage of the ulcer area, but it is incompetent. So when the doctor treats the feeder vein with the foam sclerotherapy, the ulcer heals. Always search for perforators around the ulcer area for the same reason. An incompetent perforator can feed the ulcer and must be treated. And report any inflammatory process found, such as phlebitis in varicose veins, because depending on the length of the inflammation, the phlebitis, it could constitute a contraindication for the procedure. And to finish, many sonographers in Brazil apply this scheme. It's like a map, and here it is possible to draw the altered veins as reported previously. The incompetent common femoral vein and the saphenous femoral junction, the segment of the great saphenous vein which has reflux, the altered perforator 3 centimeters below the knee, and the ulcer with its respective feeder vein. Can you understand now what is a feeder vein? It is a varicose vein. A varicose vein, usually it is connected to the saphenous vein, and it is incompetent. So the ulcer area is not properly drained. So it causes the ulcer. Posteriorly at the level of a calf, the 4 centimeters segment of a small saphenous vein, which contains reflux, is drawn here. So in this scan, we also draw any varicose veins, the most important varicose veins found, not all of them. Okay, this is for the right leg. Yeah, we have a similar scheme for the left leg. I don't know if you apply this scheme. Who applies this scheme in your practice? It's very, very common in Brazil. Well, that's all I have for today. I hope you have enjoyed and I have shared the useful information with you. Thank you very much for attending.
There is one question that came up.
Yes. So, ulcers seen on the lower legs may suggest incompetent veins. Yes, most of the time, ulcers have a venous etiology. In some types of patients, for example, diabetic patients and patients who, how can I say, smoke. Sorry, I've lost the word. There is another type of ulcer, an arterial ulcer. But usually when we have swelled limbs and ulcers which is secretive, most of the times they are from venous etiology. So we must search for incompetent veins.
Okay, so well, I would like to thank Dr. Costa again for a great presentation, very informative, lots of information, lots of details. It's great to hear how protocols are formed or how certain procedures are done in different countries. And it's really cool to see the similarities and also the differences.